my pleasure to be on this TV show on guidelines, on the HIP guidelines on pneumonia and on the future French guidelines on beta-lactam monitoring. And on this TV show there is Frederick SJÖVALL from LEONE, Sweden, and Jeffrey LIPMAN from Brisbane, Australia, who are two the most experts in the field of antibiotic treatment and management in the world, probably. And I co-chair this show with Claire Roger from Nîmes, who is also a world-class expert for antibiotic management.
Good evening.
Evening. Thank you for having us.
Thank you for coming. So to start, Jeffrey, you are now in your intensive care unit, and one of your patients has fever, is mechanically ventilated, and he has purulent sputum and the white blood cell count raised. So I ask you, what do you do? Should we start antibiotics, and how can we avoid to overtreat this kind of patient?
So the crux of the problem is to, and I presume on top of what you've told me, you've grown some gram-negative organism from the sputum.
We don't know yet, but probably.
So the crux of the problem is to define an inflammatory response with colonization from an infective response. Even if you don't grow, but there's a lot of causes of a white cell count, a fever, and purulent sputum in the intensive care unit that is not an infection. The classic problem would be atelectasis, which can cause a fever by itself. The purulent sputum will be a reaction to a lot of things, including the endotracheal tube. So you really need more information before you just start shooting with antibiotics. Every antibiotic has collateral damage. In fact, there's a good French study showing that after imipenem use, within a day or a couple of days, patients will develop or excrete imipenem-resistant organisms. So you can't automatically give antibiotics, and what you're doing then is just changing ecology and creating problems down the line. So you really need to know, is this patient infective or is it not infective? And without other signs of organ dysfunction, I would wait.
Okay, thanks. So let's say now that he has septic shock, is on vasopressors, and there's gram-negative bacilli in the pulmonary samples, so he's getting worse. So which antibiotics would you use in that context? He has been admitted to the ICU 7 days ago.
So you shouldn't be treating the patient's ecology from Boston or from America. So the HAP and VAP guidelines from the American system don't necessarily apply to your own system, and you hope you get some ecological data on a monthly or 6 monthly basis of the organisms that are grown within your, either in your intensive care unit or certainly in your region and in your country. So for example, a patient in Greece would need different antibiotics, particularly because they've got very resistant organisms, would have different empirical therapy to a patient in New Zealand that has virtually no resistant organisms at all. So your treatment would be based on local ecology to cover the most common organisms, and you can never cover 100%. You can never cover every single possible organism. So you go on reasonable cover for your ecology in your area. In Brisbane, we would start on Piperacillin tazobactam, and I presume in France you'd start on the same. as against Greece, would need different empiric antibiotic therapy.
Okay, thank you.
Frederick, do you agree with this rational approach based on the ecology, and which are the criteria in the patient history and the severity of the disease you can take into account to introduce an antibiotic and to choose the right antibiotic?
Totally, I certainly agree, and also would like to emphasize then from the beginning, if you do have first of all, you do have the sputum, you have the fever, you even might have a positive culture, but even then you should allow yourself to maybe wait and to see how it develops, because it's not necessarily, it's a difficult and narrow line between the colonization and that you really have an invasive infection that you need to treat. So there, I think you can be a little bit watchful. You don't have to rush in. You have time to think. You have time to wait for almost up to certainly the next day, as long as the patient remains stable. In the next scenario, as you explained there, when you do have a patient who seems to be in shock, low blood pressure, the norepinephrine is going up, and you can really see that this patient is much more severely sick now. Then I also agree there with Jeff that you do have to then go in and based on your local ecology, you do start some kind of antibiotics. In our unit, we would also likely choose PIPTAS based on, you could also argue for cefotaxime, which would be our a little bit more reduced. Many people, if there is a septic shock, you would like to be broad from the beginning, so people would still be a little bit reluctant to only go with the cephalosporin. So yeah, I think we do have more or less the same approach, and we're also coming from more or less the same ecological background. So again, we are not in Greece, or we're not in a high in an area with a high MDR.
So you would not use combination therapy to treat this patient? None of you would?
We are a little bit of in a disagreement here, so I would not. I think if you know your ecology and you're quite certain that you will hit the organism that you are targeting, if you give enough of a good bolus or high initial dose and you cover it, then it's enough to give one antibiotic. And then I'll let...
So when you say combination therapy, do you mean gram-positive and gram-negative, or double gram-negative?
I would say double gram-negative.
Okay. Leave it like that.
And if you want to broaden your spectrum of activity, not for synergistic activity.
No, that's fine. I think if you've got a prevalence of about 15% MRSA, your empiric cover should be vancomycin. If your prevalence across the ecology or in the hospital is 10% or less, you probably don't need to start with vancomycin, and piperacillin tazobactam or ceftazidime, provided you dose adequately, is fine.
In France, most physicians in this case would add aminoglycosid or fluocinolone, either one or the other, because it's in the French culture to add antibiotics. What do you think about this practice?
Frederick's got a meta-analysis, and he's just given a talk at the Société on exactly that topic.
I mean, as I said again, I think if you're likely to cover the organism that you know that's provided by your local ecology, and you know what to a certain amount of percent that you are sure that you cover, I would not use it. But if you do have a resistance problem, you do want to more, it's again looking at the combination as, are you just adding something on top, or are you actually broadening? And if you are broadening, of course, because if you're giving something that's resistant to what you're giving, you might as well not give anything. So if you believe that you are broadening your therapy and you're not sure and you are in an ecology that you have to do that, then either you can say that then using the aminoglycosides, that means that you are sparing maybe the meropenem or the carbapenems or the really broad. So then I don't also have an issue, because then it's broadening, but then just doing it on when you have a low resistance level and putting it on top of each other, I think it's enough to die one time.
So I think the point that Frederick made in his talk was all the data has been retrospective and old, and now that we know that we should dose properly on pharmacokinetic and pharmacodynamic principles, if you dose properly, there's no good evidence to show that one good dose of whatever you give with the ecology is any worse than adding a second agent. That's the message I got from your talk?
Yeah, exactly. And I think that's because we've been moving quite hastily with the knowledge coming mostly from Jeff and his colleagues for the last 10 years, that we now know so much more on how to give and dose the antibiotics. Before it was just one dose fits all, and we know now that that's not the case. So if we just apply that knowledge that we now have, I think that could be a good way of actually reducing and not so using a really targeted therapy. And by using a targeted therapy, you can more safely then cut back and not use so much redundant therapy.
So there is a rationale to broaden the spectrum with another antibiotic, but there is no rationale to use 2 antibiotics if my level of resistance is pretty low.
That's
yes.
That's what I was saying.
And Jeffrey, which would be for you the best administration mode for piperacillin tazobactam in this patient?
So I think there is no doubt that you need to give a bolus dose to start. That's non-negotiable. That's the correct thing to do. I think there will be an article that I'm writing with a lot of European co-authors in intensive care medicine, and I'm just writing the antibiotic guideline part, or the antibiotic part of a bigger discussion. And the diagram I gave was you probably need 1 to 1.5 times the standard dose the first time, and that goes for a lot of the drugs. But to answer your question, piperacillin tazobactam, you probably need 4.5 bolus, and you may want to give 1.5 amps, which will be 6.25 or 7.25, whatever. 1.5. You need a bolus dose to start off. You've got to give a bolus dose when the bacteria are dividing the most to get the best level and the best pharmacokinetic data. So that's a given. After that, the question then becomes how often you dose, and that depends on clearances. And Frederick had a nice concept in a pharmacokinetic masterclass on Saturday, where you've got a bathtub with water in it. You've got to fill up all the spaces in the water, independent of anything else. And then the clearances are related to the drainage of the water or the plug. But you've got to have the bolus dose up front, independent of anything else. Then you can look at your clearances, and then there's the debate of, I presume the question relates to continuous infusion versus bolus dosing. You need to keep a level above round about 4 times MIC. It's not I don't want to go into the subtleties of that, but if you've got significant bathtub plug with big drainage, big clearances, even a continuous infusion may not be adequate if your clearances are high. And so you probably should, whatever way you do it, either continuous infusion or bolus dose, see that you're giving enough with high clearances. So the pharmacokinetics of continuous infusion suggest that you keep your level high, which is important, but every now and again with high clearances, not even that's enough. So what we do, we measure levels every day and we keep our minimum level or our continuous level high.
And do you use off-label dose? For example, you can use it 24.
Yes. So that's a common question wherever I go in the world. In 1991, I published a big article on single daily aminoglycoside. That has changed world practice. Virtually everybody now uses single daily or extended interval aminoglycosides. That is off-label. If you look at the package insert on aminoglycosides, it says give it in divided doses. So I don't think anybody in the world should be using the registered label of aminoglycosides anymore. You all are using it off-label. We do it, none of us talks about it anymore, and it's a given thing to do. However, nowadays people are saying, why are you giving off-label vancomycin when you give big doses, or off-label beta-lactams? It doesn't make sense because we're using off-label anyway on aminoglycosides. So yes, we use off-label. Virtually every patient in my ICU has off-label treatment of antibiotics.
So, Frederick, do you have therapeutic drug monitoring in your routine practice in your ICU?
I would like to say yes, but we don't yet. It's just up and running. So the clinical chemical department of our hospital has just started. So it was tested and put into place during 2017. Starting now slowly in 2018. So we do have the means. Still, there is a big educational problem. It's just a task to go through. I believe we don't use so much aminoglycoside. If we do it in a single shot, and then that's it. So you don't really have to monitor. Everybody's now, after many years, used to using vancomycin. And most of my colleagues have a feeling on how to dose, and when they get the numbers back, that they can adjust to that. But if I would tomorrow go back and say, hey, let's, this guy send for this meropenem, this cefotaxime, or, and to analyze, it comes back and they will see a number, and I don't think anyone would know what to do then. So there is an educational task to start with.
So how can we do without TDM to adjust drug dosing? If there's any other option?
I would say measure clearance, I would say, would be one. I'm not quite sure that all units measure clearance. It's an easy way to do it. You don't have to do 24 hours. You don't have to have the big box. You can do it, I would say, for 8 hours. Then you have a very good accuracy in your clearance. And doing that means that you can then see, are these patients going, up into what's then called augmented renal clearance, or this patient going in towards a renal failure, and then you can adjust according to that. It will still, if you don't know what you're actually having in your concentration, it will still be a best guess, but it's a better guess compared to not having the clearance at all.
Can I just point out what Frederick's saying, because that's very important. Most of our patients in intensive care will have a urinary catheter. Pediatrics is slightly separate, but the adults will have a urinary catheter. Most of our patients will have a serum creatinine in the morning as a standard procedure. You can collect urine from midnight to 8 a.m. You then have a volume of urine. You've got your morning serum creatinine. You've got that volume, and all you need is a measurement of creatinine in that volume, and then you've got UV over P, and you've got 8-hour creatinine clearance. That would give you a good estimation of how that bathtub empties and therefore clearances. And if you've got normal clearance, you can give your package insert, which is unusual. But what happens is that your clearances in young, often we've done a study, multidisciplinary ICUs in 4 countries, 65% of patients that have normal serum creatinines have augmented renal clearance. So when your clearances are above 120, 130, you need to increase, or you've got to increase the daily dose, either with the continuous infusion or give increased divided doses, 6-hourly or 4-hourly peptides with high clearances. So if you haven't got monitoring, I agree with Frederick, measure the clearance, and if your clearances are normal, you're safe. But there's data from a lot of places now that we've been underdosing a lot of patients.
I want to come back to the first dose, on the bolus dose, because most physicians are afraid to use large dose in patients with renal failure or at risk of renal failure. And I would want to make very clear that the first dose is independent of renal function.
Correct. Yes, I think it's one message to be stressed, that yes, it's again, the bathtub, it doesn't matter how big of a hole you have in the bottom, the bathtub is still the 100 liters that you should fill, you should still fill it. Then it's a question, once you filled up with your bolus dose, then you can start considering how much is actually going out. If it's a very small trickle, then you can wait until the level falls, which will take longer time then. But for the first dose, then you just fill it up with the bolus dose.
Second point.
So let me just get that clear. You have renal dysfunction and you want to use an aminoglycoside. If you can debate whether you want to. It is no use at all using a small dose of aminoglycoside when you've got renal dysfunction. The way the aminoglycosides work is you need a high peak. It's, if you give a small dose, not only are you not getting the peak, but you're getting the side effects of aminoglycoside with no benefit. So you either decide to use aminoglycosides or not, and when you decide to use it in renal dysfunction, you have got to use a big loading dose. Otherwise, you mustn't use aminoglycosides. You need a big loading dose for vancomycin. You need less of a loading dose, but as I say in that article, 1.5 times your standard dose as your loading dose for most of your antibiotics.
That's around 6 grams for peptides, for example?
Yeah, 4.5 or 6 grams, but certainly you need a bolus dose. The beta-lactams is not that important to give higher than the bolus, but you can, but you need the bolus dose the first time.
Okay. Now I have my patient with continuous infusion and my concentration is low, it is underdosed. How can I manage to be efficient in a short time without any delay to correct the underdosing?
So what we would suggest, we don't use continuous infusion, but that's a different. If your continuous infusion is low, you need probably half a bolus, half the dose again to get it up, and then increase your daily infusion. So let's say you're using 4 3 to 12. You're using 14 grams of piperacillin, is that right? Or 12 grams of piperacillin. 12 grams, 3 4 to 12. 12 grams of piperacillin as a continuous infusion, and your level is low. You probably need half an ampule, which is another 2 grams of piperacillin, 2.4 bolus, and then instead of the 12 grams, you need to increase it to probably 16 grams to keep it above your lower dose. So you're either going to do that on creatinine clearance or measure a level. If your creatinine clearance is very high, you need more than 12 grams a day. And if you give 12 grams a day and you measure creatinine clearance and it comes back high, you've got to give another bolus and then 16 grams a day as the next infusion.
Do you monitor side effects, especially with beta-lactam and neurological effects, like in patients with sedation, especially, or patients who can be comatose? So do you monitor in this patient with very high dose of peptides, for example?
So there are two side effects of the peptides. One would be a combination of nephrotoxicity with other drugs, which I think is overemphasized, and the other one is neurotoxicity, which is very difficult to measure in the ICU because patients are sedated. And the point about the neurotoxicity, it is reversible. So in other words, if you do find it, if the neurologist comes and you can't find another reason for the spasticity or the or some seizures, if there's no other cause and you want to drop the dose or stop the drug and use another drug, it is reversible. I think that the beta-lactams, provided you measure creatinine clearance, or provided you haven't got significant renal dysfunction, you can measure creatinine clearance. Effectively, you should measure the drug, but the neurotoxicity, although it's in the literature, is uncommon. It's uncommon. If you're dosing, it's usually with significant renal failure that you continue the 8-hourly piptaz, that they get the high dose, or the big one is kefapine.
Frederick, if we know now that from the microbiological lab, the MIC of the gram-negative bacilli is quite high, let's say 8 milligram per liter.
Yeah.
What should we do? Should we change our antibiotic therapy? Could we just adjust the dosing based on these MIC results?
I suppose it's a little bit depending on if it's 8 and you would like to be on 4 times the MIC, then you would come up to 32, be up, which would then be considered quite high as a concentration. What you can do with monitoring and knowing is that you of course you have a better way of seeing the risk harm ratio between that. Even though you go up, if you have a high MIC, you don't necessarily have to say this is a resistant organism, this is, you just have to stop and change. If you're happy, you can go up, and then you know what you're having and you know what the level. So you can argue that the 4 times the MIC is for having a room to having fluctuations over day and so forth, and to be really secure. If you then have the MIC, you might argue that you don't have to be all the way 4 times. So then you can still, if you have 8, you can go to 16, which is double, and then you can still that could be treated. But sometimes, of course, the higher you go, even though you can't go, to extreme levels of your beta-lactams also, then you have to change.
And you need TDM to do that. Without TDM, it could be risky too.
Ideally, for the resistant organisms, or the not so much resistant, but for the organisms with high MICs, if you want to use that drug to that, so your MIC is going to be related to the organism and the drug. And if you get a E. coli or something with an MIC of 8 to piperacillin, you may want to change to a carbapenem, and there's some data that is probably better. But you can, with TDM, titrate your pharmacokinetics to the MIC with relative safety, provided you can measure the levels. But if you can't measure your levels, you probably, with higher MICs, the microbiologists or your ID physicians are going to pressurize you to change anyway.
Just a short question and short response, please, because we are in time, on the stability of antibiotic in continuous infusion.
All right, so the drug companies in their package insert are going to say you need bolus dosing. No drug company is going to give you the medical legal support that you can use it as a continuous infusion, because that's off-label, and they go into medical legal issues if you do that. Most of us are going to use off-label antibiotics, including either extended infusion or continuous infusion, if you believe in that with beta-lactams. The stability of the original compounds with piperacillin, tazobactam is good, no problem. The carbapenems have less stability over time. Doripenem has less, I think it's 8 hours. Meropenem is a bit longer, and imipenem, I've forgotten the stability of imipenem, but meropenem, we've done stability testings, can be left up for 12 hours with reasonable stability. It probably is stable longer, but we in our lab have done stability testing and it lasts 12 hours. We believe that the newer generic companies, because the compound's the same and the drug composition is the same, we believe that the stability will be the same. No drug company is going to tell you that or allow you to use continuous infusion because it's off-label. It's a bit like asking them, can you use big doses? They're not going to allow. They're not going to say yes.
Okay. So it's time to close the discussion. Unfortunately, that's very short. I want to thank Frederic. I want to thank Jeffrey for their nice comments and their judicious response. And thank you, Claire, for being with us.
Thank you. Thank you for
so
having
much.
us.
Thank you.